Danny, thanks for coming on.
Thanks for having me.
Absolutely. This has been a while in the making, coming.
Right.
So you are a neurologist.
Correct.
And that's the term. You're a neurologist. Are neurologists known as any other term?
No, but we do get confused with neurosurgeons a lot.
Gotcha.
So I always have to explain I don't do surgeries. That's the neurosurgeon. But if we find a tumor or something that needs to be operated on, we refer to that specialty. But we're neurology, so our field is anything to do with brain, nerves, and muscles in the central nervous system or the peripheral nervous system, or PNS, that we call it. The different types of disorders, runs from migraines, headaches, to like multiple sclerosis, epilepsy, dementias, movement disorders such as Parkinson's, neuromuscular disorders like myasthenia gravis. It's a good variety of different
stuff.
Different disorders, different type of patients.
So what about all those things you just mentioned called your name to become a neurologist? Like when you were a kid, is that what you pictured, or do you just want to be a doctor?
No, actually, I wanted to be what my dad was, which was an accountant, and my dad hated being an accountant, so he convinced me otherwise. And then when we moved, I grew up in Israel, and I moved here when I was 14, and then I knew I wasn't going to go anywhere like liberal arts or being an attorney. I didn't like to argue. I didn't like to, I guess, express myself too much. Writing essays was always a nightmare for me. So I knew I was going to be something in the sciences. And long story short, UCLA, when I went to undergrad, I tried different classes in different science-related fields, computer science, and of course all the pre-med stuff like chemistry and biochemistry and all those, physics. And, it wasn't until I did biology, I was like, this kind of makes sense. I like this. We also have doctors in the family. So, of course, there was a little bit of an influence there. But, I think once I started doing the biology classes and volunteering, and I was a biology major, and then my older cousin, who's also a neurologist, he was a neuroscience undergrad at Berkeley.
Oh, wow.
And I went to visit him, and he was showing me the lab and all this research. I'm like, yeah, that sounds a little bit more sexy, neurology compared to biology, especially as I was thinking med school. I'm like, oh, what looks good? What looks better, right? It's all a little bit strategy as well, when you're trying to get to med school, but ultimately it doesn't really matter as long as you got the grades. And in fact, just an aside, to be a good, well-rounded student for med schools to accept you, you're better off actually being like a non-science major, such as like econ or philosophy, history, whatever, and then do your pre-med and of course do well in it. And that's better for people anybody out there who wants to go to med school. Think about doing it that way. It'll be better for you that way long term.
Interesting.
Yeah.
Now, why would that be better?
Well, because everybody else who applies to med school is usually like the same typical cookie cutter. Oh, I'm going to be some science major, right? Like biology, neuroscience, psychobio, like that was different fields. And UCLA, there was like every couple of years, there was like a different popular, type major to be, or the more attractive major to be. That's like, so my years was neuroscience. After that, I think it was psychobio. Also, there's physiological sciences. That's one of my roommates in med school was that major. Some people actually made their own majors. You could be creative, I guess, depending on the college, right? So UCLA was sort of open to that. So, yeah.
Wow.
Yeah.
That's good information.
Yeah.
So you decide I want to go into neurology.
Right.
And now how long, you didn't start med school yet at this point?
No, so I was a neuroscience major. Switched, during my first year in college, and then it wasn't until I was in my third year, my first upper division classes in neurology, that we had a neurologist come by and kind of do his sort of like show and tell, so to speak, of how they conduct the neuro exam. And I thought it was like very unique because it's very, it's kind of like a detective work kind of thing, where like, of course, just like anything else in medicine, you get most of the diagnosis just by asking the right questions and getting the right answers, and trying to put it together. But, when the neuro exam, it's a little bit different than your general medicine doctor who might just listen to your, heart, lungs, maybe palpate the abdomen, because we also have to kind of do an exam based on the neuroanatomy. So, and that's where it gets kind of unique and interesting, and that's why I liked neurology, because of that, figure out where the problem is, where's the lesion, so to speak.
So there's a lot of question asking in your field.
Yes, there is.
Lots of question asking. Would you say neurology, compared to other, you said the word before we started, compared to other fields, what's the term? What would be the term between like neurology? Specialties.
Yeah. Mm-hmm.
So would you say neurology compared to other specialties is more using your mouth and head rather than like hands? Is that one way of putting it?
You could look at that. Yeah, I mean, I hope it's not going to offend anybody, but like I had a friend of mine who in med school, he asked me like, what field are you going to go into? Because like during your third year of med school, you have to like start deciding what field you want to apply, and then your fourth year, you actually go on interviews, etc. And I was trying to decide between different things, but ultimately I decided neurology. And he's like, yeah, no, neurology is like, excuse my term, the language here, it's mental masturbation. You have to like think a lot, which is true. I'm a kind of, I guess that's kind of fits my personality. I like to be in my head sometimes to my detriment, but
same here.
Yeah. so it's a lot of like theories, right? It's like what I explained to my patients, like when they present with symptoms, and neurology is not black and white like it is in surgery, like, oh, you have this and we have to take it out, or you don't. A lot of it is, what could it be, because you get these constellation of symptoms, like somebody comes with like numbness, tingling here, and then a headache there, and you have to kind of make it all fit together, and hopefully to one picture of, sometimes it could be multiple things going at the same time, but obviously the most simplest explanation is the best. So you always have to like put like what we call a differential. So, what could it be? Most likely, second most likely, and then the least likely, but different ones.
So
yeah.
It's interesting. So, gosh, just by you describing this, it must be, it sounds daunting. If someone shows up with a headache, it's like, where do you start?
Well, there's certain disorders, certain disease states that are like, unless the patient tells you something that's a red flag terms. So, for example, in the case of headaches or migraines, if somebody tells you they have the worst headache of their life, or a headache that they've never had before, or a headache that hasn't gone away since they had it, maybe it's coming up 2 weeks, then you got to be worried about, serious stuff like, God forbid, aneurysms, or such as bleed and causing bleeds, or tumors, or infections. But, statistically, day to day, most people who I've seen for headaches have already had their headaches for many years. They may or may not have seen a specialist such as myself. They may have just gone to their primary care doctor, who may have tried treating it with different, modalities. And of course, it wasn't successful. Otherwise, they wouldn't be seeing me. So that's when they finally come see a neurologist. So.
Interesting. So neurologist is the point of so you're not the first one I go to. You are the one who my primary care doctor sends me to.
That depends. I mean, this day and age, and like the type of patients I see are mostly patients with, up until recently have PPOs, and so with those type of insurances, you don't have to see a primary care. You can go straight to a neurologist if you know where to start. A lot of people, especially young people now, are very tech savvy, so they. For good or bad, they tend to Google their symptoms. And so they know that, okay, this could be this could be this, and therefore they know if they go on like WebMD, they say, oh, you should go see this type of doctor. So they may come straight to me because of what they've researched themselves.
Whoa.
So, yeah.
How often do you get someone who shows up and says, I Googled such and such, and they're way off? Or not?
Man, if I had a penny for every time that happened.
Really?
No, it's true. Yeah, it happens a lot. It happens. I mean, and people themselves kind of tell me like, yeah, I Googled it. I knew I shouldn't have, but now I'm worried. So that's why I'm here. I'm like, okay, I get it.
Yeah, Google.
Yeah.
Do you as a doctor feel like you are up against Google? Or is Google pretty much along the lines
Google is bad and good for us neurologists, because I mean, it's bad for the patients because it makes them worried. I mean, it's good for us as a business because, we get to see those type of patients, and, they're what we call the worried well. So we just need to reassure them. And, a lot of times I do my exam, and because I spend a good amount of time, I was telling you earlier, I spend a good hour with each patient. Some neurologists, most neurologists don't do that. And because of that, I ask the right questions. I let them ask questions. I even ask them, like, what do you think it is? And they tell me, well, I looked it up and they said this and this. And then I give them my reasons why I don't think that's right, or I don't think that's what they have to worry about. And most of the times, because I'm good at reassuring them, they're happy, they're okay. But sometimes they're like, I understand what you're saying, but can we still get a MRI or this test? I'm okay with that. I'll do it, Unfortunately, when it comes to insurances, though, that's where the issue is, because sometimes insurances, if you order too many tests, they start causing issues for the patient, and not so much for the doctor. I mean, it doesn't hurt us, but like the patients end up getting a test and then it's not covered, and unfortunately they have to pay the cost of it, basically. So if it's not covered.
So just because you mentioned insurance, let's talk about insurance a little bit. So I've heard from a few I was talking to a dentist who was actually was mentioning something with insurance and what they accept and don't accept. What would be some upsides or downsides to medical people accepting insurances or not, like from your perspective, from your end of the stick?
Yeah, so the world of insurance has changed over the years. I mean, I wasn't around like 10, 20 years ago when supposedly people I know in the field who used to be in that area told me that, you could still take insurance and you didn't have to spend only 20 minutes per patient. You had time, you didn't have to rush, you didn't have to see so many to make ends meet. But as you know, the state of the world or country and the cost of healthcare and everything kind of put everything in a different shift. So, as the years gone by, the insurances and Medicare, for example, have been paying less and less per patient interaction, even for the same type of tests, even for the same amount of time you spend with them. So unfortunately, for the patients, it's like it becomes like you get what you pay for, right? So a lot of doctors who are kind of like me now, who are trying to not take insurance, we do it because we have no choice. Because if I want to spend the amount of quality time with a patient and still like provide good care and, make enough money for the business, because ultimately I am a business, I can't afford to be with insurance. And so a lot of patients, especially depending on the demographics where you are, where your office is. I'm in an area where, thank God, like there are people who are able to afford it. If I was in another location, for example, where there's less affluent people, that wouldn't have really worked that well, for me at least, because, maybe people can't afford. But unfortunately, as much as I hate to say it, is ultimately a financial thing too, when you run your own private practice.
100%. So when you say that you ultimately won't be able to afford with accepting insurance, in what way would accepting insurance make you less money?
Well, because, if for me to make the same amount of money and take insurance, I'll have to see double the amount of patients. That means I can't spend as much time with each patient. And therefore, it's just a bad thing. I don't like to rush patients. And that's what people like me, because I don't rush them. I let them talk and ask questions, and I ask questions to them. And, so people like that.
It's like a therapy session.
Yeah, in a sense, I am sort of a therapist, a pseudo-therapist, and sometimes. I do like to go a little bit into mental health, but not too much. Whenever it's necessary, whenever it's needed. But, the point is, it's not feasible for doctors who want to only see X number of patients a day to still also accept insurance, unfortunately. I'm as I was mentioning to you earlier, like this month I stopped taking PPOs, but I'm still with Medicare and people with Medicare basically. And so, I think it's fine. It's doable. I mean, we'll see what happens in the next 5 years or so. Things change all the time.
Right. Interesting. So it's because you don't want to compromise on the quality of care that you offer.
Right.
That you won't make it like a revolving door.
Yeah. I mean, I don't like to not see certain patients. I mean, like, because of my new policies, for example, it feels like it's a little bit skewed towards more older patients because I still take Medicare, but, and it makes it less of a diverse population of patients I'm treating. But at the same time, I have to look at the big picture for me kind of thing. So
Yeah.
Yeah.
Love it.
Yeah.
I wrote down a few terms
Yeah.
that I researched and that neurologists deal with.
Mm-hmm.
And honestly, I have to be honest here. I've heard many of these terms before.
Mm-hmm.
Half of them, I have no clue what they are.
Okay.
And the first one is, maybe I'm crazy, maybe I'm the only one, but epilepsy.
Mm-hmm.
What's epilepsy?
Epilepsy is basically another name for a seizure disorder. Or
So you know what? You said the word seizure. Let's start with seizures, because I'm not even sure I could explain to someone what a seizure is.
Yeah.
What's a seizure?
So the way I explain it to my patients is, brain cells, they communicate with each other using electrical signals, electricity, right? And if you remember from biochemistry, it's the movement of ions across the cell membranes creates a voltage gradient, and then eventually get the action potential, which, ends up releasing neurotransmitters, right? And those neurotransmitters cause voltage changes in the next cell. So in the global picture, it's electrical currents and different frequencies, different modulations of impulses between cells. And so they're not supposed to fire the same amount the same way. What seizure is or what causes seizure, when you have a group of cells, brain cells in your cortex, that start firing synchronously together, same rhythm, same frequency, same amplitude, all that kind of stuff. And they may just be localized to one part of the brain, and that's when you get the people who get those weird, not the typical what we call tonic-clonic, where they go into whole body shakes. They may just be like, they start off with what we call automatism, where they get lip smacking, they start doing something in their shirt, they start doing a fencer position where one arm might come out, and then they start turning one side of their head to one side, and that's a what we call focal seizure. It's a seizure that's only on one side of the brain. Ultimately, that same group of cells can start recruiting other cells or other neurons, and then that's when the patient goes into a full-blown tonic-clonic. So tonic, the whole body gets stiffened, their eyes roll back, they usually fall, because they lost their balance because they all went stiff. And then once the cells are trying to sort of reset, that's when they get the whole clonic, the whole body like this. And, there's certain things that go along with seizures, there's this thing called post-ictal state, right? So after ictal means the state of seizure, post-ictal is post-seizure. And that's when the brain's trying to recalibrate all the chemicals that got sort of shifted. And then, patients are tired and they're out of it. And then you hear about them, because of their state of tonic, they bit their tongue or they lost their control of the bladder. And, typically a patient says, one thing I'm like doing this, and the next thing I know, I'm in the hospital in the ER, or the paramedics are already there. That usually means they probably had a seizure. And for the most part, seizures are not life-threatening unless a person is known to have lots of seizures, and some people can die from seizures if they go into what we call status epilepticus, where they have sort of a short circuit where their brain just keeps firing, like a short circuit, where just frying itself because the cells are just keeps firing when they're not supposed to, or they're supposed to stop eventually. And some people can die of what we call SUDEP, which is usually seen in people who are prone to seizures, and then they stop taking their seizures cold turkey, and then they pass away in their sleep. And they don't know why exactly. It could be that they asphyxiate because of their seizures and they are in a bad position. But that's something that's always been studied, and it's a real risk for people with epilepsy. So
wow,
yeah, you always have to tell patients with epilepsy never to stop taking their meds cold turkey.
Interesting, because it's a shock to the system.
Yeah, that and they go into like a status epilepticus, like a continuous seizure, or where they can't breathe and they can't support their respiratory and vital signs. All these other things go out of whack when you have a seizure continuously. So
Wow. Do we know what causes seizures?
So everybody can have seizures. It's different things can cause it. Some epilepsy disorders or some seizure disorders are genetic.
And by genetic, you mean it just happens?
Meaning there's a family history. So for one reason or another, the genes of the person predispose the cells to be more likely to fire abnormally than somebody else who doesn't have seizures, like me and you. But technically, anybody can have a seizure. You can cause a seizure to anybody if you give them the right meds or cause enough damage to their head in a certain way or apply enough shock to the brain. Kind of like, you know what ECT, electroconvulsion theory is, electroconvulsion treatment, or ECT is sort of like causing a state of seizures in a person who has major depression, which is more of a psychiatry realm. But
it's interesting you mentioned the word depressed, because when you said it's in someone's genes, like they're more prone to, would you say it's similar to like someone being more prone to depression because it's in their family history?
Yeah, you could say that. Yeah, I mean, depression is a little bit on the more ambiguous side because it's kind of genes and environment, and there's a factor for there's a role in each one of those factors to cause something, but ultimately, what I was trying to say with the genes for epilepsy is like normally you have a family history of somebody with primary generalized seizure disorder, a generalized epilepsy, which is the types of seizures where you don't have that auras or premonition that you're going to have a seizure. A person goes straight into like a full-on tonic-clonic type event. A lot of those seizure disorders are benign. There are some that are a little bit more serious and are lifelong, but the benign ones, there's certain type epilepsy types that are the kids grow out of basically after a certain age. So, which is good news because that means they don't have to be on lifelong seizure medications.
Whoa.
But also, there's a lot of factors. It depends on what their EEG electroencephalogram shows. If there's any lesions or focal abnormalities in their brain MRI that can eventually cause other type of seizures or focal seizures. So there's different things that we do to assess overall risk of having future seizures when we do this workup.
Wow. So when do seizures typically happen? Like, is there a time? Is it in the sleep, or is it all times of the day?
Right.
Is there?
So there's different ways for a person who's prone to seizures to have their threshold lowered so they actually have a seizure. There's certain states in sleep where people are more prone to seizures because of the change to like deeper sleep and to make it not too complicated, but the thalamus, which is a regulator of rhythms, it kind of shifts during sleep. And so there's certain parts of sleep where people are more prone to seizures during their sleep because of that. But other than that, other things can cause lowering of seizure threshold. For example, people who are prone to seizures, even if they are on medication, if they drink enough alcohol will lower their seizure threshold. If they get enough head traumas, that can lower seizure threshold. And even people without seizure, genetic reasons for seizures, can eventually get seizures because of that. For example, people with many traumatic brain injury episodes or incidents, I should say, like athletes are prone to that. Dementia patients can eventually get seizures as their dementia progresses. It all has to do with the state of your neurons, your nerve cells.
Wow.
So how healthy or how robust they are versus not robust. So
do people get seizures in your office often?
While they're
there?
It doesn't really happen that often, believe it or not. I mean, I've seen a few times in my life where they actually had it while in the office, but usually they already have had their seizure, they've already been to the hospital, and the first step for me is to determine if it was really a seizure or not. If they've never been diagnosed with epilepsy or seizures, that's the first step, is to see if they actually had a seizure. And a lot of times you can, again, like I said, 80% of your diagnosis could be made just by history. So if you know what questions to ask or to elicit the right answers from the patient, you can make the diagnosis. You don't really have to do too much of a workup. I mean, I'd still do other tests such as MRI brain if they haven't had one, or an EEG to look at their brainwave activity state. But sometimes it's not clear cut, because patients may pass out. And passing out by itself can cause somebody to have like a little bit of an arm shaking, for example.
Yeah.
But usually the main difference is like from passing out, a person wakes up relatively quick. They are not confused. They're not out of it. They're not tired for like half a day or several hours after the incident. And they usually have some sort of what we call pre-syncope. Syncope is another term for passing out. So pre-syncope auras or symptoms. So like, for example, classical is I start feeling my heart beating abnormally, and then my vision gets darker, and then I start hearing ringing in my ears. That's kind of implies low blood flow. So the reason the person passed out there is not because the brain cells started firing abnormally. It's more like a secondary occurrence where the blood flow wasn't enough to the brain, and therefore the brain sort of has a episode because of that.
Whoa.
So it's a secondary cause, if you will, but it's not epilepsy in a sense. It's more of a syncope, which is a cardiovascular issue.
That is so interesting. It's so interesting that you deal with. Now, would you say strokes make up the majority of what you deal with? Seizures, I'm sorry, not strokes.
Actually, no. To be honest, the bread and butter for primary outpatient neurology, general neurology for me would be actually more the migraines, the headaches, and then the more older patient issues such as, neurodegenerative disorders such as Alzheimer's dementia or other type of dementias or Parkinson's and those kind of things.
Yeah, there are a few of them around here.
Mm-hmm.
So I guess headaches make sense, would be your bread and butter, because everyone has a headache every once in a while.
It's a very common thing, yeah. 40 million people, 30-something million people.
Is there a way to explain in a few words what a headache is and where it comes from? Like, how does all of a sudden I have a headache?
Right. So, there's headaches is the actual umbrella term, and then within the headache realm, there's the different types, right? So the way that the main bodies of medicine, especially neurology, the International Classification of Headache Disorders, they like to categorize the main two camps, if you will, is the tension headaches and then migraines, and then in between you have all these other types of headaches. So the tension headaches are the headaches that most people get. Everybody in their lifetime will get at least one of those, which is, from dehydration, for example, or stress, where they just get this pressure in their head. It's like a vice grip. It's not too bad. They can still work through whatever they're doing, even with a headache. They don't have any nausea. They don't have any vomiting. They don't have to go to a dark room. And usually goes away with enough over-the-counter medications. That's a tension headache in a nutshell. There's other criteria to that. If you want to be more specific, you can, look at those diagnostic criteria. But migraine is sort of, think about a headache, but like a really, really bad headache where you get these symptoms I mentioned, the nausea, vomiting, light sensitivity, sound sensitivity, maybe smell sensitivity. Definitely, person, you ask them, what happens when you have the headache? Oh, I have to go to a dark room. I can't work anymore. That headache is like a 10 out of 10 in a scale of 0 to 10, as far as 10 being the worst pain. And sometimes the patient needs to go to the urgent care or even the ER because they may not take the medication they're supposed to in time. And then by the time they take something, the headache's already full-blown, the migraine headache, and they can't stop it. So they have to go to the ER, they have to get some IVs or maybe an injection like Toradol, one of those drugs, and hopefully it stops it.
Whoa. So I'm assuming dehydration, food poisoning, and a bunch of other things, the symptoms could all be the same. It's like a bad headache.
They can. Yeah. But migraineurs or people with migraines are also like a breed of their own. Like there's a lot of genetics to patients with migraines, right? So typically a patient with migraine would have typically, not always, but at least one family member with a history of migraines.
Got it.
And especially if their father has true migraines, then the kids are more likely to get migraines themselves.
As opposed to the mother.
Yeah.
Why is that?
There's, for some reason, I don't remember the specific details, but like there's some reason like that when a male person has migraines, then their offsprings are more likely to get migraines.
Wow, that's fascinating.
And there's other things that kind of go along with migraines, like people who have motion sickness are also people who are more prone to migraines, or, a couple other, pain states that like people with migraines just have a lower threshold for pain, for example.
Whoa.
So, there's a lot of other comorbidities, maybe a little bit of fibromyalgia, there's other type of pain disorders that people with migraines are more prone to. So,
that's so interesting. Headaches. It's a fascinating thing because they happen all the time.
Right.
And so it sounds like the more we talk, the more I'm sitting here thinking, not only to be a good neurologist, you need to be a great question. You need to know what questions to ask, right? Because it's all about the diagnosis.
Mm-hmm.
That's why they come to you. But I'm assuming the more you do it, the better you get at it.
Yeah,
and you
true.
could become much more efficient.
That's true. Yeah.
You could rule things out much quicker.
Right.
Interesting. So the goal would be to go to a really old neurologist who's been doing it for 70 years.
Maybe, but at the same time, not to toot my own horn, but older neurologists, the older, not just neurologists, but I think doctors in general, the older they are, the less, it's not, of course, universal across the board, but the older doctors, they're sort of used to what they're trained in. And even myself, I admit, you're only as good as how your training was. So if you've been trained 50 years ago where you didn't have all these advances, you may not be thinking about what other options you can give your patient, unless you're one of those doctors who's very involved in, and hopefully you are, somebody who's into what's the newest thing out there. And that's when it's kind of nice to be sort of involved with industry in a sense, because when you allow, let's say representatives from pharmaceutical companies come by, they can sometimes educate doctors who are like, oh yeah, that's right, there's this disorder, and you learn about this. And also you might be able to, you should hopefully be able to learn also just reading journals, because we do have to do continuing medical education. But, in the private practice world, it's not, it's not always doable because time commitments and everything else. So it's nice to be able to keep your head to the ground and always be in touch with what's new out there, and also not just treatments, also just disease states. There's something we're always, and that's one of the things I like about neurology, is because something I learned 10 years ago might not be true as much anymore. And so you're like, oh, okay, great, now we know that this does this. For example, certain risk factors for things like ALS, right? Lou Gehrig's disease. More and more data comes out. We know that certain exposure to certain chemicals might predispose somebody to have ALS. Not necessarily 100%, but for example, one of the things we recently learned is people who have been exposed to embalming fluid.
What's that?
People who work with cadavers, in mortuaries and stuff when they have to prepare the body.
Got it.
They're a slightly higher risk of developing Lou Gehrig's, for example.
Whoa.
Yeah, or people who have been exposed to certain type of chemicals in gas, gasoline type of thing, like military aircraft, for example, or possibly a little bit more prone to certain things, not just ALS, but even things such as Parkinson's, for example.
Whoa, and this data is just recently coming out.
It's been coming out throughout, here and there sporadically, but there's always more and more other researchers who look retrospectively and try to collect population data to try to see if there's a correlation between a certain disease state and exposure to certain things. It's not always easy, obviously, because there's always confounding factors. But if you have a good sort of academic center with good statisticians and academicians, they may be able to interpolate what's going on. But forget about also causes, also pathways, mechanisms. For example, in the world of migraines, in the last 10, 20 years, we learned that there's a certain pathway, for example, the calcitonin gene-related peptide pathway, where you get, or the reason why you feel the pain you feel when you have a migraine or even a headache. There's certain chemicals, like calcitonin gene-related peptides, that get released by certain parts of your midbrain, your brainstem, and that sort of starts the whole process. So because we knew the pathway, or the scientists figured out the pathway, they knew what type of chemicals you can apply or medications you can try to stop it from happening. So now we have a new generation of anti-migraine medications. They're for example, once-a-month injectables. which have been game changers. Before that, we had mostly off-label oral medication somebody had to take every day, twice a day or once a day, depending on the medication. And now we have what we call the Anti-Cgrp Antibodies. I'm going to mention some specific brands like Ajovy, Emgality, Aimovig, which are been, phenomenal game changers when it comes to prevention of headaches. Just because we figure out what the mechanism, we sort of fine-tuned it and we figure out a little bit more in detail what's going on at the pathway level and what can we do to stop the headaches.
Wow.
Yeah.
In the grand scheme of things, so just hindsight's 20/20, but best you can estimate, how early on in this whole field of neurology are we as in the world? Like, do you think 100 years from now we'll look back at 2022 and laugh at how little we knew, or do we know relatively a lot?
Yeah, I mean, it's not going to be a easy, short path. It's going to be a long ways forward. I mean, for example, dementias and things that where we call neurodegenerative disorders, we still do not have cures. I mean, one thing I can mention is back in June of last year, there was a new medication that came out called Aduhelm or aducanumab, which was the first of its kind that was approved by the FDA to slow down the progression of Alzheimer's disease specifically. And it was doing it by binding to the amyloid beta, one of the actual proteins that become abnormal in patients with Alzheimer's. Unfortunately, the data from the pivotal trials, the main trials, wasn't so robust, and now it's still very controversial. But the point is that there's still a lot we do not know about a lot of these disorders, especially the neurodegenerative disorders, the ones where we lose brain cells and we just don't know how to regenerate them. Brain cells are very hard to regenerate, especially the ones, the central nervous system cells, I should say, as opposed to the peripheral nervous system cells. So hopefully one day, maybe even our own lifetime, we'll be able to get to something like that. I really honestly believe that, nanotechnology is going to be a big thing.
What do you mean by nanotechnology?
So nanotech is, think about microscopic robots, if you will.
Okay.
They're able to be, they're going to be the size of a virus and be able to go into your cells.
Whoa.
And make genetic changes or build proteins that your own genes can't build anymore. And that will be possibly one way to stop loss of brain cells or maybe even regenerate new cells.
So is this the thing? Like, it's happening?
It's very early in its development stage, as far as I know. I haven't really looked into it in a while, but it's definitely much an up-and-coming field.
That sounds crazy.
Yeah. That's probably going to be a wave that people are going to be living to more than 100 for sure. If
you did that.
Yeah.
They could probably reverse aging at that point.
It's potentially, yeah.
That's crazy.
Yeah.
Okay, you mentioned dementia, and I have it down here.
Sure.
Dementia, we hear that all the time.
Right.
So what's dementia?
So dementia is the umbrella term to describe any person with cognitive deficits. Cognitive deficits is the typical, short-term memory is one thing you always hear people with dementia have. But in order for them to be qualified per criteria for true dementia, they also have to have difficulties in doing independent activities of daily life. For example, patient with dementia will have, let's say, problems forgetting certain details of certain things, forgetting to pay their bills on time, forgetting details of conversations just had earlier in the day. They may have even changes in personality, their mood changes. And we're talking about people who never had, let's say, depression or anxiety. And then, now they're in their 60s, 70s, 80s, and they're a completely different person that they used to be. They may have problems with visuospatial. For example, Alzheimer's patients, they get lost because their specific lobes of the brain, the temporal and parietal specifically for visuospatial, they lose brain cells that can process that. So a typical patient with Alzheimer's type dementia may start getting lost, wander around. Typical story is, person who's been driving to the same place over and over, and eventually they're like, they can't figure out how to get there anymore. Or they really have to start using an aid, such as like a GPS device when they never had to do before.
My grandfather had that.
Yeah. And there's different types of dementia. Dementia, again, is kind of like headache, right? So dementia is the broad term, just like headache is the broad term. And then within the dementia realm, there's like the Alzheimer's type dementia. There's the second most common is a vascular type dementia, which is like mini, tiny silent strokes that cause cumulative effect with your brain cell loss. There's Lewy body dementia, there's frontotemporal dementia, and then there's like the more rare type of dementias. So it's a pretty broad field.
It's the headline term for people forgetting things.
Right. In short answer, yes. But there's different ways. There's different reasons to forget things. So because I just want to say something about that, because I always get young people who are like, oh, I think I have dementia. Statistically speaking, very young people, like I'm talking 20s, 30s, 40s, even 50s, to have dementia that age is relatively rare. Unless somebody in your family actually had true dementia in their, again, very young age. That's more of a genetic type of thing which can happen at a much early age. But when I see a 20, 30, 40-year-old, let's say, with, I'm being forgetful, more likely than not, it's not really a cognitive issue. It's more of an attention issue. And, that's when the questions I ask them about their mental health come into play. I mean, are they depressed? Are they anxious? Or something on their mind that they're not focusing on? They basically not being, like, the new term is mindful.
Interesting.
So,
wow. So it sounds like dementia is more typically in older people, where seizures, you mentioned, it could go away for kids.
Yeah.
It sounds like seizures would be in younger people, or am I reading into that wrong?
Well, it's not that simple. Seizures, the generalized epilepsy syndromes can be in younger people that eventually goes away if they're the benign forms. But then people can have seizures throughout their lives from other secondary
the
causes.
Whole life. Got it.
So, brain trauma, other damages they may have done to their brains from drugs, alcohol, etc. Or also as they get older, again, if they become really demented, for example, Alzheimer's patients, for example, can eventually down the line develop seizures. That's a little bit more on the rare side. But yeah, epilepsy is seizures, a little bit on the younger side, but sometimes still on the older side. It's all basically, it's all a spectrum, right? I mean,
it sounds like it's all pretty much the same. It all comes. Yeah. Now I get why you deal with all these things.
Yeah,
because it pretty much comes down to the brain cells.
Right. I mean, you have to put it in a context, right? Like if you see an older person who's never had migraines or headaches before in their life, and now they have headaches, then you have to be really suspicious that they really have a true migraine, because certain disorders like migraines, it's very rare for people over the age of 50 to have their first onset of migraines at that age. If anything, a lot of people, especially women, have their migraines stop after their menopause. Because, and the theory is something to do with no more shift in hormones and, the ups and downs of hormones throughout the menstrual cycle. So a lot of females actually have no migraines anymore after. I mean, they may have a different type of headache, but once in a while you still get females who, like, they're in 60s and they still have their same migraines they had when they're younger. But for the most part, it's not. But then if you have a person who never had a migraine or headache, a really bad headache, and now they're in like 60s, you got to be worried about something else, something a little bit more serious.
Interesting.
Yeah.
So Alzheimer's is a type of dementia, and epilepsy is a type of seizure?
No, epilepsy is a seizure disorder. Basically, 2 or more lifetime seizures that were unprovoked would qualify to be considered epileptic.
So epilepsy refers to like how often I get seizures.
Epilepsy refers to you having the propensity to get seizures.
Gotcha.
Yeah, if you only had a one lifetime seizure in your life, basically, and then you knew what the cause was. For example, you had a head trauma, right? Sometimes after concussion, people can get seizures. So that is your first and only seizure. We wouldn't call you epileptic. We won't call this an epilepsy disorder because you only had one lifetime and it was provoked. It wasn't unprovoked. If you had 2 or more unprovoked seizures, meaning there were no causes that you as a physician can ascertain, then more likely than not, this is an epilepsy. And then the reason why it's important is because if it's epilepsy, then they need to be on medications to prevent future episodes.
Ah.
Because again, if you have somebody with epilepsy and they have recurrent seizures, it's like we say seizures beget seizures. And it's also kind of applicable to migraines. We just say migraines beget migraines or headaches beget headaches. So whatever the state is, it's like sometimes it goes to short circuit and it's just like a loop that you have to stop somewhere. So that's where these medications, the anti-seizure medications, come into play. They stop this loop from going on and on and on, or from recurring, basically.
Whoa, that is so interesting. I want to shift a little bit from talking about these conditions and stuff, and talk a little bit about your job.
Yeah, sure.
At the people you deal with.
Sure.
So you mentioned before you spend, and actually I read or watched it today when I was looking into neurology, that it's a field where you stay with your clients, could potentially for many years.
True.
Right? As opposed to other fields. So because you deal with people who have dementia and some other deteriorating conditions, potentially, how difficult is it, or how, I'm assuming if you start with a patient who has mild dementia, if they stick with you for 5, 6, 7 years, now they probably don't even know your name. So how do you deal with that?
Yeah, it's it's hard, but it's mostly hard for the family more than anybody else, because it's the family that obviously has to deal with the day-to-day issues that occur because of a person becoming forgetful. The funny thing is, a patient who has real full-on dementia, when they come to see me, a lot of times either they're in denial that they have dementia, or they're not basically cognizant of it. It doesn't bother them, basically.
So the one with dementia, it is never bothered by it.
Well, I take it back. If it's a very, very early onset dementia, which is something that the new medications are being applicable to, like those type of patients that are very early, those patients usually come in and they're aware that they're having issues. And that's on the sad side, because they go from being aware that they're having issues to just being happy-go-lucky with, like, all right, I don't have any issues anymore. In fact, they still do, and it's probably getting worse.
Fascinating.
But the ones that come to me who are already been diagnosed with dementia, usually the family that brings them. It's obviously not the patient themselves, because they won't be able to even bring themselves if they wanted to.
Right.
For different reasons, and they're not even aware that they have it. So it's not a problem for them. It's a problem for the family.
So dealing with a dementia patient, you're not really dealing with them. They're always accompanied with a family member.
Usually. I mean, once in a while I get the early onset type of dementias that becomes a little bit tricky. I've had a couple of patients where they would come by themselves, and, they're still, early or pre-Alzheimer's dementia where they can drive themselves, they do some stuff, but they're aware, they're noticing that they're having problems with work, or people telling stuff, and they're like, wait, I have this problem? I don't know. So now they, go see their primary care doctor. Like, the doctor's like, okay, go see a neurologist, right? And so it gets a little tricky for us neurologists, because we like to get collateral information, right? And so I always like to have, a family member, somebody who knows the patient well, of course, not just somebody who hasn't seen the person in a long time and doesn't know anything about their health.
Right.
But, I have had a couple of patients where, unfortunately, they're very hesitant to start having their loved one involved, because for different reasons, either they don't want them to get worried about them, or, they don't want to show sign of weakness or something, pride, that kind of stuff. So it gets a little bit tricky, because obviously you want to do what's best for the patient, but if you're starting to feel like the patient can't take care of themselves, it gets a little bit dicey,
Wow.
Legally kind of dicey, because if you feel like a person might be dangerous to self because they're not taking care of their medication, or, or they'd say they're driving when they're not supposed to, for example, that's a common thing that we see. We as physicians, whether it's neurologists or not, doesn't matter. We have to report to the DMV, for example, if somebody, even in cases like seizures, for example, we by law, and every state is different. So it's a good and bad, because, we do a public service by preventing, God forbid, future issues from occurring. Like you always hear the cases of, patients with dementia who shouldn't be driving and who did drive, and then they got into a major accident, or they ran over a whole bunch of people. Like there was that case many years ago in the farmer's market. And
it was dementia.
I mean, the guy had some cognitive issues, but I guess maybe the doctors didn't think it was that bad, but apparently it was. So, you know, and it's not so much just even remembering stuff. It's like also things that change as you get older is your ability to react, right? Like, let's say if it was a young person who had the same problem, like put their foot on the gas instead of the brake, they can shift their brain like, oh, shoot, let me change. But an older person also has a less reactive time, right? Just like in pilots, right? There's a reason why airline pilots, right? Correct me if I'm wrong.
You have to retire.
After what, 65?
65.
Right. Because
you know a lot about flying.
like I said, you know, in the alternate universe, I probably was a fighter pilot, but
I love it. I love it. Yeah, I know, 65.
Yeah, 65, right? But a lot of them also get to kind of fly on the side for like private jets and stuff.
Right. So there's the only requirement to retire is the airlines.
Mm-hmm.
You could fly. You could use your pilot certificate.
Mm-hmm.
And I take that back because I actually don't want to say something I don't know. Either it's only the airlines or to exercise your... No, that doesn't make sense. I was about to say ATPL certificate. Doesn't make sense. It's the airlines. I want to say it's the airlines.
What made him decide on 65? What was that?
It's the FAA. You know, so the FAA, the governing body of all this, really to keep it simple, and this is the life of a pilot.
Mm-hmm.
The way the FAA approaches pilots and airplanes is the more risk is associated, the more buffer we will put in place to prevent a potential disaster. So in other words, let's say that airline pilot flying 300 passengers from here to China is on the top end of that spectrum, meaning the most amount of potential risk. And on the bottom end is just you, the pilot, in your own little small, tiny plane on a Saturday afternoon. You alone, there's really not a lot at all that goes into you maintaining currency and being able to fly. You could do that when you're 90. But when it comes to all that risk, there's a lot of things involved, such as recurrent training. Your medical certificate level has to be more stringent. Your checkups have to be more often, as well as retire at 65.
Right.
But many people go from there to other gigs, even like flying corporate, or you just flying their own plane.
Right.
And so they do that for many years after that. But for the airlines, it's 65. Yeah. So I'm with you that people get older, it's different.
It's different, yeah. I mean, it's not to say that 65-year-olds can't fly. You know, they could still be as good as like a 20-year-old. But I mean, ultimately, if you look at it in like a microscopic level, there's definitely going to be slowness in reactivity between a 65-year-old and a 20-year-old, right? I mean,
totally.
That's why military pilots are usually in the 20s, 30s, supposed to.
Totally. Yeah, there's a few older ones, but it's generally you're at your prime. Ish. You need to become a pilot now.
I know, seriously. I'm talking about it. I went to the air show yesterday.
Yeah, be a pilot doctor.
No, a flight surgeon actually is something that it's always kind of floated in my head. And I'll tell you a funny story. One day I went to do a volleyball class, you know, in Santa Monica, and there's this woman who was also in the introductory class, and then I just started chatting with her, and it turns out she's a family practice doctor. And I asked her about like where she works. Like, oh, I'm this, but I'm also a flight surgeon. I'm like, oh, you're a flight surgeon? Tell me more. And so it turns out she works for the Air National Guard because her husband is a F-15 pilot.
Oh, wow.
So she was trying to tell me about, oh, you know, if you talk to this guy, you can maybe even just volunteer like on certain weekends, because, you know, it's like Air National Guard. You only have to do so many days a month, or I guess, right, per period. But I mean, I might not be there yet because I have too much stuff going on in my own life right now. But something I always thought about.
Look into. Surgeon, but could you do surgery?
Well, from what I understand, flight surgeons doesn't mean you're a surgeon. You're just a physician that deals with pilots.
Interesting.
Yeah, that's the term.
And you're on the airplane.
You get to do backseat rides, which is one of the reasons I wanted to do that F-15 Air National before the F-15s get phased out. They're going to get phased out eventually. But I want to do a backseat.
I love it
because there's no two-seaters F-35, so I got to get
flight surgeon.
Yeah,
you need to get on a fighter jet.
I know, seriously.
Bad.
Every time I see those like VIPs in the back, I'm like, how the hell do I become a VIP like that?
There must be a way to like buy a ride.
Maybe not in right, but in Russia before, you could get on a MiG-29, a two-seater, and they take you.
They take you up.
Yeah, I mean it's like 30,000 or something for the flight, but so for some people it's nothing, and they can afford it. It's sort of
Wow.
So
That's
right
incredible.
Yeah,
That's incredible.
it's cheaper than going to space.
Oh yeah, I mean, but soon we'll
Right.
all be going to space.
Some of those MiGs can go really high up. I don't know if you've ever seen those YouTube videos.
No,
They go up to like the edge, like 100,000 feet.
100.
Yeah, they can. I mean, they probably can't stay there too long, right? Because of the whole pressurization
That
and
is
stuff.
crazy.
Yeah.
I need to look into it now
Mm.
that you say that. 100,000 feet.
Oh yeah, there's amazing YouTube videos of that.
Whoa.
Yeah.
That's crazy.
Mm-hmm.
So, neurology. There's so much to dissect, but just I'm trying to keep it with the. So when it comes to dementia, you mostly deal with. Tell me this: how quickly do you see the deterioration of someone showing up and then a few weeks?
So so statistically, the average lifespan of a person after diagnosis of dementia is about 10 years.
Wow.
Yeah.
So dementia kills you.
It's not so much that the dementia itself kills you. It's your inability to do certain things. Ultimately, what kills a person with dementia is not so much your own brain dying. It's more like you become sort of like a vegetable.
Oh.
So you become bedridden, and that by itself causes other things, right? You get bed sores, you get infections, like you can't clear your lungs, you get pneumonias, and eventually you can get what we call sepsis, right? And bacterial infection or infection in your bloodstream, and eventually that's what can kill a person if it's not something else. Like a lot of times dementia patients also wander, right? And they fall, and that's what they always say, like an older person with a hip fracture, that's like beginning of the end, unfortunately, for a lot of, not everybody, but a lot of older patients. Because once they lose mobility, they lose, ability to stay, functional.
Wow.
So, mobility is key as you get older.
And eventually, as it progresses, they don't know who you are when they come visit you.
Yeah, but by that time they can't even come to the office.
They don't come to the office.
They're basically in a nursing home.
So what would be the purpose of visiting you with dementia? Is there medication for it?
That's a good question. So unfortunately, because I mentioned there's no cures, there are certain medications that we've been giving for a long time now that like specific classes, for example, Aricept or donepezil, which is a medication that's supposed to allow the brain cells to keep acetylcholine still in the system between the different brain cells that are communicating with each other. Because acetylcholine is a chemical in the brain that's one of the many neurochemicals, but a main one that gets depleted or doesn't get processed well in patients with Alzheimer's. So this medication, for example, doesn't reverse anything, but it may... What I see with patients, not everybody, but some patients, that they get to be a little bit more focused or sharper during the day. They don't, for example, a patient before and after the medication. So before, they keep asking the same questions over and over and over again. After the medication, they seem to be able to retain short-term memory a little bit better.
Wow.
Yeah. But unfortunately, as you get more progressed, there's only so much those medications do, and eventually... it's not enough. And so we sometimes add another medication, such as memantine, or it's an NMDA antagonist. It tries to stabilize the brain cells by blocking influx of calcium, because calcium is actually toxic to brain cells. Influx of calcium. That's what causes cell death in the brain, or actually any cells, really. So supposedly that has a membrane stabilizing potential. So that's more reserved for like moderate to severe. But ultimately, even with the two medications on board, a person's still going to progress. And that goes back to that other medication I mentioned, the aducanumab, which unfortunately is controversial. However, that being said, there are other companies. So that is manufactured by Biogen, a big pharmaceutical company. But there's other companies now coming out with their own similar type of drug. It will be interesting to see what the FDA and Medicare decide to do with those drugs. I guess it'll be all dependent on the data they're going to be able to present to the FDA.
Whoa.
Yeah.
What's the difference between Alzheimer's and dementia?
So dementia is the umbrella term. Alzheimer's is a type.
So Alzheimer's is one type of dementia.
Yes. Yeah. So like I was saying, dementia, Alzheimer's is the most common type of dementia. After that, it's vascular dementia. That's people with like heart attacks, strokes, or cardiovascular risk factors. Like say if you had high blood pressure, high cholesterol, diabetes, any of those or all of those, they can develop their own type of dementia we call vascular dementia. And it looks a little bit different than the Alzheimer's type dementia, but ultimately it leads to memory loss and difficulty with executive functioning and difficulty with doing, things that they were able to do before.
Whoa.
And then the third most common is the Lewy body dementia, which is sort of like a mix of Parkinson's and Alzheimer's, where they get a little bit of like possibly tremors and some movement disorder issues, but they're also very sensitive to medications. They may have a little bit of hallucinations. That's Lewy body, which, again, unfortunately, none of them are reversible. We as neurologists, our main goal is we'll figure out hopefully what type of dementia, if we can. It's not always easy, and there's different ways to do it, but there's no one test that tells you this is this type of dementia. It's like a picture of it's a mix of all these things coming together, all these symptoms and signs and what the family tells you and what the MRIs and maybe the EG and maybe the neuropsych testing, maybe the PET scans, all these different tests you can do. But, it's interesting because at the end of the day, the question is, does it make a difference?
Move the mic a little closer to you.
At the end of the day, does it make a difference?
You could lean back. Just move the mic. Yeah.
Does it make a difference in what you do? Because, again, there's only so much you can do for a patient with memory loss. Once you start that process, there's no reversing.
Wow.
Except for
crazy.
except for those IVs I mentioned that can potentially slow down the progression, but we're still not sure yet.
Insane. I heard you guys, neurologists, work closely with neurosurgeons.
Yes.
How would that come about? Like, in what ways do you work close with neurosurgeons? With which type of patients and what circumstances?
So for me, for example, like common case is a patient that I see and I suspect maybe a tumor, and we do a brain MRI, and there's actually a tumor or some mass, maybe not a tumor like a typical sense, but there's some sort of mass, and now the neurosurgeon needs to be involved in order to decide what they want to do with this. How do they want to work it up? Do they need to do a biopsy? Do they need to resect it? All these kind of things. That's when the neurosurgeon gets involved. Or sometimes, for example, another classic example is like we do a brain MRI and incidentally find an aneurysm, which is basically, an outpouching of an artery's vessel wall, which can eventually bleed if it becomes large enough or big enough, or cause a bleed. So that's when a vascular neurosurgeon especially, needs to be involved to sort of assess. Maybe they need to do further testing, maybe like an angiogram, to really know the real size of it. Because with CAT scan MRI, you can only get so much detail. Our buddy Saman can probably speak to that. But ultimately the neurosurgeons need to get involved if they need to do something about it. If they need to maybe clip it or coil it, that kind of stuff.
Wow, that's crazy. So should everyone become neurologists or no? And if not, why not?
It's funny because in med school, like the good thing about going to neurology is like most people do not want to be a neurologist.
Really?
Yeah. No, because it kind of goes back to like the disorders that you can't treat, right? And people are like, oh, it's so depressing. You got all these disorders. You can't do anything about it. Yeah, that's true. But who knows? I mean, it's possible that even our lifetime, maybe end of our lifetime, but still, there will be treatments for these disorders, and you learn something new all the time.
That's right. I didn't think of this. So many of what we talked about, so many things of what we talked about this evening, there's really no like straight up medication. Like
there's no cures or reversals for I think like, for example, in the fields where I feel most fulfilled, or the disorders, I should say, where I feel most fulfilled is in migraines. Because I feel like we are, as neurologists, we're pretty effective, if we know what we're doing, we're pretty effective in figuring out what type of medication to give to the patient. Of course, ultimately, it's the patient's responsibility to be on those medications, of course, because if they don't take it, we can't do anything for it.
Right.
But other type of disorders I feel really fulfilled when I treat is a person with Parkinson's, for example, because even though we can't reverse what's going on in their brain because they are losing brain cells, there are lots of medications out there, especially classic old medications, that you really see before and after. And it's amazing, as a neurologist, to see that.
So you're not curing it, but you definitely see a difference.
Right. You give them a good quality of life. That's what it ultimately comes down to, is can you improve their quality of life?
Is that what you keep at the forefront of your mind as a doctor all the time, and you try and keep a zoomed out focus on, with everything you do, am I improving the quality of life or am I not in the macro? And does that determine like the specific micro stuff that you do? Is that something that you think about often, or are you just focused on the treatment and the specific?
It's a little bit of both. It's for example, in migraine world, we have to consider offering patients medications once their migraines are more than like 4 a month, or if they have two migraines a month, but they're very debilitating, or they don't respond to medications per guidelines. The American Headache Society, you have to offer a preventative, right? So it's a cost benefit type of thing, right? You could give a medication, but then any medication, even supplements, can carry side effects. So you have to look at it, as a whole, and ultimately it's the patient's decision, right? You can't force it on a patient. You give him options. You go over the pros and cons of each, and hopefully your patient can make an informed decision and go from there.
Wow.
Yeah.
It's so much to it. It's so interesting. Today that you're a doctor, is it everything you thought it would be?
That's an interesting question. I think that, I never thought of myself as working in the private practice world, and so which is what you do today. Which is what I'm doing now, which is a different beast than what I was in training. Because in training, it's a whole different, it's academic, and actually we used to do a lot more stroke work. I don't see that many stroke patients unless I take call, and I do take call at Seizures, but not that frequent. So, it's a different environment, right? It's different. But as far as I'm glad that I'm still a neurologist. I'm very happy that I'm a neurologist. The business side of medicine, unfortunately, is not it's not as good as I wished it could be.
That's so, I think most professions could speak to, there's the profession, and there's the business side.
The business side, yeah.
Even in flying, there's
right.
flying an airplane,
right.
and then there's the business side of
right, of course, like you, right.
And I totally hear you on that one.
Yeah, because that's the thing. In med school and residency, they don't train you for a business part of it. They want you to focus on to be a good doctor, and that's what you really think of when you go. Like my first job after residency, I'm like, I didn't care about billings and codes. I'm like, who cares? I'm a good neurologist. The patient's good. They like me and I'm doing a good job. But for the people who are hiring me, like, no, you have to understand, you have to like put this code, because if you don't, then we don't get this much. And I'm like, okay, fine. So you kind of did it begrudgingly. But now that I am a business person, I'm like, oh, I've learned so much about billing in the last 5-6 years I've been in solo private practice, more than I ever wanted to know.
Whoa.
And now that I'm kind of trying to get out of the insurance business, that's sort of like a pushback, I guess. But yeah.
Yeah, I actually spoke with a dentist once who was telling me exactly what you just said.
Yeah.
You spend all this time learning your profession, and no one prepares you how to run your own practice, and how to hire and be an employer.
Nope. And we doctors in general, we don't like to be confrontational, so it's hard, because we like to have a good working environment, because that's what we're used to. We're in a hospital setting. We had support from our attendings and other residents and, nurses, and we all hopefully worked good as a team. But when you're in a private practice and you run your own business, you got to bring all these people together, and you sometimes have to kind of be like a babysitter, make sure that everybody gets along together, and, kind of do like, hopefully, if you're big enough, and that's what I'm trying to do now, I'm trying to find an office manager that's going to help me grow in, maybe add more personnel, because, it's not easy to do that, especially if you don't have the knack for it,
Especially if it doesn't come, and especially if they don't. Why don't they teach you any of this business management in med school?
I guess it depends on the attendings you had. See, my attendings are great people. They were amazing neurologists, but they just assumed that everybody's going to be fine, either they went to private practice or worked for Kaiser. But like in the world of medicine now, like Kaiser's the ultimate job to get, because it's like a big institution. It's kind of like being in residency. You have people kind of taking care of you. You don't have to worry about the billing and all that kind of stuff. You just get a salary. You get bonuses. That's the most coveted type of employed position, at least in California. Kaiser's not big in other places, but here in California, Kaiser's a job to have. If you're going to go work for somebody, you want to work for Kaiser. Other than that, though, if you work for yourself, it may have been easy, again, 20 years ago, 30 years ago, when the insurances were paying good enough. But as the years gone by and insurance would pay less, a lot of doctors, now they have to hire a PA or a nurse practitioner to help them see like total of 40, 50 patients a day, in order to make ends meet. So they can pay the rent, the overhead, all that kind of stuff. It's very hard.
Crazy.
Yeah.
What do you like most about your job?
I like the variety.
What do you mean?
Being a general neurologist, like I was saying, I can see young patients with like headaches and other type disorders, maybe epilepsy and MS, those kind of things. But at the same time, I can, shift and I see older patients. And
Right.
The thing I like about just being a physician is, this type of physician, I'm not like a radiologist, or no offense to radiologists out there.
I don't even know. I've heard the term. I don't know what I need to get one on here, but.
Well, we have a friend.
Oh, Saman. So is that legit what they do? Look at the scans?
They just look at scans all day. I mean, once in a while you get the interventional radiologists that actually have to do something with the patient. But that's what I'm saying. I have a variety. It's like every hour, if I'm busy, every half hour, I see a new person in front of me.
Wow.
It's not like I'm stuck, in a cubicle looking at a monitor kind of thing.
So it is, I guess when I think about it, more than other specialties, you are all over the board. Young, old,
right.
Beginning of the way.
Right. I mean, I could be more subspecialized and, just want to see just dementia patient or just Parkinson's or just this. But then I'm putting myself in, pigeonhole. Like, right. I'm just going to be stuck with those type of demographic type patients. So, and I like the variety. So that's why I'm happy being a general neurologist. So,
what out of all the stuff you treat, which one requires most of you? Which one is the most daunting thing to deal with?
I mean, they all can be in one way or another. Like, there's always going to be, migraine or headache patients that are just, no matter what you do for them, they don't respond, right? Or, of course, the dementia patients when they are just too much for the family to handle because, behavior issues. That's, that could be daunting. So basically any type of disorder, you can have the extremes. Not all, most of them are not, but there are always going to be some extreme type patients where, again, whatever you put them on, they just don't respond, And, I'm lucky to be, affiliated with an institution like Cedars-Sinai because they have their subspecialists, those neurologists that just see this type of headache or this type of disorder, that type of disorder, I can refer out. So, but I mean, I still try to do everything in-house. I try to deal with it myself. But once in a while, you got to do what's best for the patient. So if you know that you've tried everything and you are not where you want the patient to be, then you need to start looking at other options, meaning, giving it to somebody who may have a little bit more experience than you.
Right, specifically in that area.
Yeah, exactly.
So you're saying as far as the most daunting, they're all pretty much across the board similar.
It can be, yeah.
If they're happening the way they should happen and nothing weird's going on.
Meaning, no, if they're not responding to the way they should be responding, like for example, like if you have the patient, like I was mentioning, who has dementia but very aggressive, and I have this one patient who we tried everything on her, and every time we try medication, either works, but then she has lots of side effects, or and then we have to take it off, and then she has the issues of aggression, for example, right? So it becomes very tricky sometimes, and those patients also, the other issue is like, it's not the patient themselves that you're dealing with, it's the family. And if the family is not comfortable monitoring the patient, or they even not even sure if the patient's actually getting the medication like they're supposed to, you're not even sure if you're actually being effective at all. So, compliance is half the battle in those circumstances.
That's so interesting.
Yeah.
That's interesting. What would you tell up-and-coming neurologists or people who are in their third year of med school trying to figure out, okay, what is it I want to do? What would you have appreciated if someone told you when you were third year about neurology that you know today?
I think, when you go into private practice, you kind of forget, or you don't appreciate the science behind it, the reason why you went to neurology in the first place. You lose a little bit of that. So a person who's still in school, just try to know as much as you can and try to be interested in that, whatever it is in the neurosciences. Because once you go in the real world, it becomes a little bit mundane, right? I mean,
100%.
it's like, okay, a patient with headache, you do this, this, and this, right? You don't go back and try to what's going on in their brain biochemically and stuff like that,
Just like, it's so amazing. Flying is so similar.
Right?
You're a kid, you want to fly,
Right.
and then you do it I was talking with someone recently about the concept of going from doing something because you love it,
right,
to doing that same thing because you still love it, but
right,
now getting paid for it.
Right.
And there's something fascinating about getting compensated to do something that almost changes the entire dynamic as a human. It's really interesting how that works. So you're saying in med school, you're not getting you're paying to be there.
Right.
And it's exciting and you're into it. And it's still exciting when you come out, but now it's your profession. It's what you do when you get compensated for it. So you're saying it's easy to lose.
Yeah, because especially if you go into private practice, being a solo private practice, you have to start looking at things in a monetary sense, unfortunately. So, you lose the allure of, what's really going on biologically. And, you obviously still want to help the patient. You still want to do what's best for the patient. But, the science behind it, all the, the biology, the science, all that kind of stuff, you kind of don't really put much focus on it because you don't have the time for that. Unfortunately, you have to be effective, and you also only have so much time with each patient. So, yeah,
that's incredible.
Yeah.
Last question: If I know you're, but you would say pilot, but if you weren't a neurologist,
right?
What else would you do in medicine?
Else?
Curious about?
So going back to what I was saying, I was sort of alluding to when I was trying to decide between specialties. I was trying to decide between psychiatry, neurology, and physiatry, which is rehab medicine. And ultimately, I decided on neurology because I felt like neurology, you kind of do all of those in one way or another, maybe more psychiatry than physiatry. But I guess I would have been a psychiatrist, perhaps,
So you're into the brain one way or another.
Yeah, it's like, it goes back to being a kid and I wonder what people are thinking of me and that kind of stuff. And I wish I can read their minds, maybe that was kind of like the fantasy behind, being a brain scientist.
Interesting.
Yeah. Like what is really going on, or why am I behaving the way I do behave, for example, there was always that
you were
curiosity.
always curious about that.
I was. Yeah. I'm still am. Yeah.
You still are.
Yeah.
Why am I behaving a certain way? You think about that.
In a sense. Yeah. I mean, it becomes a little bit philosophical, of course, and, psychodynamic, that kind of stuff, whatever you want to call it. But that was part of the allure when I was growing up, when I was, thinking of becoming a neurologist, that'd be cool, I could figure things out about myself. That's like what they say, people go to psychiatry, that's because they have some issues themselves and they're trying to, or psychologists too, no offense to those professions, but it's true, it's to some degree, they
don't want to figure it
they're trying to,
out.
Yeah, maybe.
That's incredible.
Yeah.
I love it.
Yeah.
Well, doctor, thanks for coming on.
My pleasure.
Thanks for doing this. Learned a lot.
Thanks.
Absolutely.
Thanks for having me.
Solid.